For Dr. Ramos, does diabetes have any connection before or after Parkinson's, and how does it interact with it if it does?
Well, as a factor that causes the disease, no, it doesn't. Diabetes is really very common, and it can complicate the treatment of Parkinson's disease. For example, I often tell some of my patients with Parkinson's disease to cut back on their protein during the day and to eat plenty of sweets during the day, or at least non-protein. And people who are diabetic can't really follow that kind of regimen, so it complicates it. But otherwise, people with diabetes also tend to develop what we call disorder of the small blood vessels, or microvascular disorders of the brain, and that can mimic, microvascular disease can mimic Parkinsonism. It can present with lower body Parkinsonism, a gait disorder. Diabetes can, because of the problem with the small blood vessels, patients will develop peripheral neuropathy who have diabetes. And with peripheral neuropathy, if it's very severe, there can be action tremors. And there can be clumsiness. There can be gait problems because of peripheral neuropathy. So diabetes, since it affects the nervous system via the blood vessels, can produce a lot of neurological signs and symptoms that to the untrained physician can look like Parkinson. They'll have a gait disorder, poor balance, they may have tremor. But they're completely different diseases. There's no loss of dopaminergic neurons as a result of diabetes. However, as a result of diabetes poorly controlled, there can be changes in the brain, tiny little strokes called microvascular disorders. We call it vascular Parkinsonism. That can produce what looks like Parkinson's disease in some of those patients. I hope I answered it. It's not a black-white answer. In brief, I can say diabetes does not cause Parkinson's disease. Diabetes, when it affects the nervous system, can reproduce some symptoms of Parkinsonism, but not clearly the whole picture of Parkinson's disease.
We were interested in getting into a research study, and we're told that if we did that, we had maybe lose our insurance. Is there any information that you have about that?
No, I don't know where that information came. I've never heard of it. The beauty of being involved in a clinical research program is that you don't have to have insurance involved at all. The visits are free. It's paid for by the study. So I don't quite understand where you get that information. But I bring out an important point. There are people that go to Singapore, China, Germany, Israel to participate in a stem cell experimental study, and they pay $20,000, $30,000 for it. That is not research. People are paying for an experimental therapy. I think there's a problem with that ethically. But in this country, clinical research that is funded by pharmaceutical companies or funded by the National Institute of Health or other funding agencies provides the cost of those patient visits. Yeah, it has nothing to do with insurance. Now, when you sign an informed consent, though, if there is an adverse reaction, if you read the fine details to the study medicine, the funder, whoever is paying the bill for the research will not cover hospitalization costs. Your hospital insurance will have to pick that up. And there's a thing you sign when you read the informed consent about that waiver. That's the only area I see there's some kind of question about being involved in a clinical trial, which typically is safe. If there are adverse effects, you can end up going to a hospital, for example. Well, hospital bills are not part of what's covered by the research.
So that would fall into your insurance.
Yeah.
We have our next question.
As a young man, I witnessed as a layman
a gentleman that I describe as having severe Parkinson's. He had very severe tremors, and he underwent surgery, and they inserted electrodes into his brain. And after that point, he was, in my opinion, about 90% cured. My question is, where is the research in that end of the field? Have they given up on it, or does it still exist, or is it used in certain cases and not in others?
You're talking about deep brain stimulation, putting an electrode into the brain of a person with Parkinsonism or Parkinson's disease, because that treatment shouldn't be done in people who don't respond to levodopa. One of the ways that we know that people have Parkinson's disease and allows you then to qualify for deep brain stimulation is to have a response to levodopa after an overnight abstinence from all medication. And if there's an improvement, means that you have a dopamine dependent disorder which is Parkinson's disease, then it's worth considering putting in the deep brain stimulator. What that does really, is alleviate some of the symptoms. In my talk, I told you about the narrowing therapeutic window, and that with time, chronic use of levodopa results in a lot of ups and downs, shorter on times, excessive involuntary movements, and off times frequently during the day. And when people fail to improve their roller coaster ride of motor fluctuations with medication and very careful adjustment of the regimen of medications, then one considers deep brain stimulation. You shouldn't use the word cure, because if you turn off that stimulator and stop the medicines on that patient that you said was cured, 90% cured, he's not cured. He has probably more advanced disease because time has gone on since he had the original treatment. There is an interesting question that's being researched about deep brain stimulation. Does it impact the disease process itself? Does it slow the rate of death of dopamine neurons? Some people claim it may, and those are the people that are saying maybe we should do deep brain stimulation right away. And others say there's no evidence that it has any impact on the death of neurons. In fact, there's plenty of evidence that it creates a lot of damage to the brain. And in fact, it doesn't help gait and balance. It can worsen depression and certainly affect speech bilaterally. So I don't really think that there's a place for earlier and earlier treatment with deep brain stimulation. And it's certainly far from a cure. We consider it palliative treatment. It's what you use when medications and very careful adjustment of medications fail to produce a good control of those motor fluctuations. I'm sorry Dr. Hauser didn't stay. If there's any, is he still here? No. He probably had another commitment.
A couple of months ago, somebody sent me a clip of a doctor from Dr. Mary Newport of Tampa, and it showed her looking after her husband who has dementia, and she gave him some coconut oil and started him on a regimen of coconut oil. And this is just anecdotal, and it's not backed up by a lot of research, but after a couple of weeks, there was a noticeable improvement. He was able to draw a clock, which at the beginning, she had him draw a clock, and it was, he drew it in the shape of a football with 3 dots in it. And then after the 2 weeks of taking the coconut oil, he was able to draw a clock with 12 numbers in it. And so she really found it helpful. And so I read other anecdotes about it too, and I started using it myself. And after a month, I did find some improvement, especially with regards to energy. So I found some improvement in my own case, in my own practice. So I'd like to ask Iman, I told her I would ask her this, and anybody else or any of you, if you've heard of or taken part or used that coconut oil, which contains no cholesterol and no trans fat as long as it is non-hydrogenated.
Thank you for the question. Well, one of the things I kind of mentioned and you kind of highlighted, hydrogenated, no cholesterol, and energy, and improve overall. You know, you feel better. Now, one of the things, with the PD and because of the medication things, the sleepiness and the tiredness and, the weight loss. So, of course, you will feel tired and lack of energy. And one of the things is with the oil that coconut oil has, well, it's mainly fat. So 1 gram of fat give you about abundance of energy. 1 gram of fat give you about 9 calories per 1 gram. While if you compare it to protein or carbohydrate, it will give you only 4 calories. So of course you're getting something, a kick right there. The other thing, hydrogenated, no cholesterol, of course is not hydrogenated. Hydrogenated really is done in the factories, and the main reason why is because to extend the life of the products, and so it can sell well. Otherwise, you lose in that. And the other thing you said, cholesterol, it does not have cholesterol. Mainly cholesterol we're getting is from the animal products, things like dairy products and steaks and no, just.
That's what I had for supper last night. She's getting on with that.
The organs and eggs, mainly that's where the cholesterol from. And we, in general, we don't really concern about the food high in cholesterol because main of the cholesterol is production is in the body from the liver. It's saturated fatty acids mainly, and as I was mentioning earlier this morning, there are some suggestions that it has to do with inflammation, and I mentioned omega-3 fatty acid because it's alter the cell wall from, we have things like called 9 and 6 and 3 omega fatty acids. So what are our problems? It's coming that we have a lot of the saturated fatty acids in our diets, and polysaturated, not much of the 9, and not much of the 3 omega fatty acids, and that's where we get into what called inflammation and production of the free radicals and the damage is happening. And as I said, chronic inflammation is the base, the root cause for so many inflammatory and chronic diseases. What I can say about it is really that the oil is great for hair and skin. It's emulsion, and it's really mainly used that. But for cooking and things, I would probably not go for it. It's just because of the saturation. That's what our problem in our diet is, the ratio between the saturated, unsaturated, and the omega-3 fatty acids. And I hope I answered your question. Did I?
I just wanted to add, I think the best way to use coconuts is with some pina colada, with a little rum, a little pineapple, and coconut juice.
Nice.
And that'll make you feel a lot better.
Actually, this question would have been directed at Dr. Hauser, but I'll try the rest of you. Is there a central location where one can find out what research studies are currently enrolling new people and what the rules are for getting involved in them?
Well, there is a place at nih.gov. It's a website, www.nih.gov, and look under clinical trials. And every clinical trial going on in North America reports to NIH, whether it's funded by NIH or not. It could be funded by a drug company. And they'll have the name of the trial, where it's being done, the kind of patients, the criteria for entry. That would be one way. But you could also just go to our PRF website, and you might find the active clinical trials, though I don't think it's comprehensive. Dr. Hauser is out there, and when he comes back, we'll ask him where he would recommend. What I would say, if you were just to call the Movement Disorders Center that Dr. Hauser runs, you'll get a list of active trials. I think he's involved in many. Yes?
There's actually two good websites, resources that we use as references. One is pdtrials.org, and it's strictly Parkinson's disease trials. And there's another one is clinicaltrials.gov. And the clinical trials one lists every clinical trial you can imagine.
Yes.
That's active and concluded.
But I think probably most people from this region want to know what is going on here. And I can tell you that Dr. Hauser's center, which has now moved from downtown up to the Byrd Center, so now it's on the main USF campus, is involved in at least 15 different clinical trials. So it would be good to call his center for information about getting involved in a clinical trial.
This is for David Hutchings. I spoke with you at lunch about vocal cord augmentation versus LSVT. If you could just address that for the group for voice problems and possible swallowing problems.
Sure, absolutely. Can everybody hear me okay? I mean, there are multiple treatments for the vocal fold dysfunction beyond just the Lee Silverman voice treatment. And kind of like we were speaking about at lunch, what really happens is that, I mean, we did talk a little bit about the respiratory issues involved, but also what happens, the best way that I could explain it is that when you take a rock and throw it into a pond, you have a nice little wave, right? We've all done that before. And that's kind of how the vocal folds begin to vibrate. With Parkinson's, what happens is the vocal folds actually begin to bow. And so they do not come together as close as they need to. So that's why we get the low, plus we have the respiratory problems, and then we also have the vocal folds not coming all the way together. So the Lee Silverman voice treatment does help address, and I hope I talked a little bit about that in my lecture, but the great thing about the Lee Silverman voice treatment is that it's not only going to address the voice disorder, as we saw surely on the video, but also the research is extending way past that to show that it also helps with swallowing as well. So anything we can do to help with increase the respiratory functioning, the diaphragmatic muscles, and the vocal fold functioning will cross over to the swallowing portion as well. So a lot of times what our clinicians are doing is the LSVT techniques, but also other proven treatments that we know help with the vocal fold and the voice box functioning as well as respiratory. So that's the main thing. We're trying to target the respiratory portion as well as trying to bring those vocal folds back together where we can get that nice little rock in the pond type movement out of the vocal folds, and that's how we're going to get a much more stronger and a louder type voice. But again, if we improve vocal fold functioning, that's going to improve swallowing, because that is one of the main reasons that we have the airway protected when we swallow, because the vocal folds come together. If they're bowed, then the airway is somewhat exposed. Did that answer your question? Okay. I'm sorry? Okay, good. I'm bad to ramble at times, so good. At least that's what my wife tells me.
This question is for Dr. Cimino. How effective exactly is cognitive therapy in relations to Parkinson's disease, reversing the negative thinking of, you know, what your brain pattern, the way it's mapped and all that? How effective is that in reversing it?
Your question was how effective
is cognitive therapy in reversing the negative thinking regarding, you know, your life with Parkinson's, the symptoms and all that?
There have already been several actual randomized controlled trials similar to pharmaceutical trials where they compare different treatments for in patients with Parkinson's disease and depression. And those trials have shown that cognitive behavior therapy is very effective in patients being able to manage some of those negative automatic thoughts. And again, I think one of the things that's really important is the theme of this conference is living well with Parkinson's. And something is going to get all of us at some point. And the idea is living through that and making those days as positive as you can make them, and living through the difficult times, and there are difficult times. Did I answer your question?
Yes. I have one more question. As a patient of Dr. Sanchez, would I have to have him refer me to you to see you? Do you treat patients outside the clinic?
I have several recommendations that I could make in terms of for cognitive behavior therapy. Also remember that behavioral activation therapy is also another very effective treatment for depression. But there are certainly recommendations I could make for therapists in the community that use cognitive behavioral strategies.
Okay.
Mm-hmm.
Do we call your office for that?
Okay.
Thank you.
Can I piggyback on that?
Sure.
Piggyback. I'm going to piggyback on that question as well. From the rehab side of things, occupational therapy plays a significant role with some of that as well as speech pathology. So, in at least in our experience, that multidisciplinary approach for some of the cognitive impairments, especially memory impairments, is really the best approach for that. For example, in our Amedisys Clearwater agency, we have those disciplines that really address some of those cognitive deficits from a multidisciplinary standpoint. Obviously, reaching out to other disciplines, but also when we look at the home and look at everything from communication to eating and bathing and toileting and all these things, when we have those cognitive deficits, obviously all those things are impacted as well. And so from an outcome standpoint, the multidisciplinary approach is really the best way to approach that. So, thank you.
My question is on Parkinson's plus disease or syndromes, such as multiple system atrophy. Does it ever occur independently, or is it only with Parkinson's?
Well, multiple system atrophy refers to the fact that much more than the dopamine system is involved, and there are various subtypes of multiple system atrophy. There's always an element of Parkinsonism in multiple system atrophy. So you can't have multiple system atrophy without a nigrostriatal dopamine problem, or at least a problem somewhere along that path. For example, in a multiple system atrophy, there may be slowness and rigidity, and the patient doesn't do well on dopamine, no response, because the real damage is downstream of dopamine. And multiple system atrophy equals Parkinson plus because there's other salient features. For example, in a form of multiple system atrophy called OPCA, which means olivopontocerebellar atrophy, there is an ataxia, a very prominent ataxia. It means incoordination of movement, not just slowness and tremor, but a very broad ataxia, wide-based gait. And that's associated with degenerative changes in the cerebellar pathways, which is back here, very important in balance and rhythm. In another form of multiple system atrophy, there's involvement of the superhighway of motor neuron action. So it's called the cortical spinal tract. They're they're neurons that reside in the motor strip in the cerebral cortex that go all the way down to the spinal cord fast, and they connect then with a lower motor neuron. When you lose those neurons, you develop spasticity, which is a different kind of rigidity than cogwheel rigidity. And you develop excessively brisk deep tendon reflexes. And if I stimulate the sole of the foot, the toes go up. So that would be also MSA. So they have Parkinsonism plus cortical spinal tract involvement. And there's some forms that involve cognitive changes plus Parkinsonism. So cortical basal ganglionic degeneration is one of those subtypes of MSA. So MSA is like a catch-all for Parkinsonism plus other parts of the nervous system markedly involved. If you remember this morning, though, we said Parkinson's disease is more than just dopamine loss. Other systems become involved. But in multiple system atrophy, there are very prominent involvement of these other systems, and they're very distinct than the systems involved in Parkinson's disease. By the way, these are really, really less common. MSA is much less common than idiopathic Parkinson's disease. Maybe 3% of the cases of all Parkinson syndromes are MSA. So they're relatively rare.
Dr. Sanchez-Ramos, I read somewhere back, either in a journal or some other type of literature, where what Dr. Hauser showed this morning was that this protein tends to unravel the spiral shape of these other proteins, and they clump up. I read, is there any research done to isolate this bad protein that causes the others to deteriorate? Is there any research done in that area?
There's a lot of research on disorders of protein misfolding. That's what it's called now.
Protein misfolding.
Yeah, protein misfolding. It's, what is that? There's another macrame, which is about folding into really elaborate. It's kind of like macrame gone wild. And every neurodegenerative disease, because proteins take on a three-dimensional structure. So think about this. DNA sequence that we inherit is a copy of a certain amount of that DNA sequence that encodes a certain protein. And it's linearly transcribed. So you have a linear protein, but nothing stays as a line once the protein assumes secondary and tertiary structures that are three-dimensional. That allows the protein to have certain structural characteristics and functional characteristics. So some of those proteins are receptors. So one of those three-dimensional proteins is called a dopamine receptor, as an example. Alpha-synuclein is the one protein that's very important in the release of dopamine and other neurotransmitters. So it's located at synapses. That's the normal function of alpha-synuclein. It's present normally. But for some reason, when it starts accumulating in an abnormal form, it assumes a conformation that cannot be recognized by the proteasome system that breaks it down to recycle it. Proteins are made, broken down, and recycled, and the amino acids that make up proteins are used. So every disease that we know that are classed as neurodegenerative diseases where there's a gradual demise or dysfunction of a subset of neurons involves an accumulation of abnormally folded protein. So in Alzheimer's, there are two of them. It's amyloid plaque and neurofibrillary tangles. In Parkinson's disease, it's alpha-synuclein. But that protein isn't just alpha-synuclein. It has a whole bunch of other compounds. And there have been many studies of Lewy bodies for a long time. The big breakthrough about Lewy bodies was when it was discovered that a mutation in alpha-synuclein that was inherited results in Parkinson's disease. And people began to look at alpha-synuclein, and they found that Lewy bodies were loaded with the mutated alpha-synuclein. And then they took that alpha-synuclein gene and did a mutation to it and put it in mice, and mice can develop alpha-synuclein. And so you have a mouse model of alpha-synucleinopathy. That means a pathology due to accumulation of alpha-synuclein. So the big thing is, how can we prevent the accumulation of the abnormal alpha-synuclein, or can we find a way to cleave it like the micro tweezers that we've heard about? So there's a lot of research going on. In the case of Huntington's disease, which I work very much, I'm involved in that, there is an accumulation of a polyglutamine, which is an abnormal protein. It accumulates in the nucleus of the cells, in the cytoplasm, associated with the demise of neurons, and it gradually spreads to involve the whole brain. Spongiform encephalopathy, or Creutzfeldt-Jakob disease. There's a variant called mad cow disease, you've all heard. And that's a really weird disease because there's no virus. What it is a prion, and it's a normal protein that once it gets misformed, it causes all the proteins, all the other prion proteins to assume an abnormal conformation, and you end up with a Swiss cheese-like brain full of a lot of spongiform holes. And that's a very rapid, dementing illness. People who ate the brains of their loved ones in New Guinea would develop a very similar disorder. And it was a person named Gajusek who postulated that this was a prion disease. Initially, they thought it was a slow virus disease, but prion disease is really a scary one because it's the only disease we know of in which, well, it's not really a living material. It's not a virus, it's not a bacteria, it's not a fungus. But if we have that in our system, we're going to develop a rapid dementia and death. It's a scary disease. But anyway, we shouldn't think of. But the insight is, the insight is, is that now we're considering that the way that prion disease is spread, which is very rapidly, has a lot in common with the way alpha-synuclein spreads. And there's something about these. The handling of these abnormal proteins that will solve the problem once we understand better how to break down these abnormal proteins. They don't even dissolve in detergent. If you were to take brain and homogenize and isolate Lewy bodies, they're impossible to digest with all kinds of acids and you know, you could dissolve a whole body but not the alpha-synuclein. So it's that kind of like difficult things to get rid of. No, but you know you just mentioned something very interesting, the post-encephalitic Parkinsonism, which was a pandemic from 1916 to 27. Millions and millions of people died. It was called the sleeping sickness. People who survived that would develop post-encephalitic Parkinsonism. Those of you who saw Awakenings kind of saw a dramatization of the discovery of levodopa, and it was first tested in these patients. So they had a Parkinson's disease, they had loss of dopamine neurons, but if you looked at their brains, what was interesting is they didn't have Lewy bodies. They had neurofibrillary tangles. The abnormal protein was within neurons, and it was a spiral, the same kind of abnormal accumulation that you see in Alzheimer's brains. The same kind of in progressive supranuclear palsy. They have what are called neurofibrillary tangles, not Lewy bodies. Remember when I said there's a lot of debate about what is Parkinson's disease? And everyone says, well, they have to have a Lewy body in the postmortem exam. Well, there are cases of Parkinson's disease that respond to levodopa, that have loss of dopamine neurons, that don't have Lewy bodies, have other abnormal protein inclusions. So post-encephalitic Parkinsonism is that. It was a pandemic. It was a virus, probably a bird flu is what people are thinking. And there was nothing we could do for it. And the sequela of a encephalitis, which means a global brain inflammation, was the accumulation of these abnormal neurofibrillary tangles and death of dopaminergic neurons. It could happen 10 or 15 years after the encephalitis. We rarely see encephalitis causing Parkinsonism now. I've seen 2 cases in 28 years.
My husband has overwhelming fatigue. He exercises and also eats well. Is that part of the brain, just Parkinson's?
Did you mention fatigue?
Fatigue,
yeah. Well, that's
fatigue.
A fascinating story because fatigue is a common symptom in depression, in Parkinson's disease. And in Parkinson's disease, I can say one thing about the fatigue. The easy fatigability, it's invariable. Everyone has that who has Parkinson's disease. Some of it may be due to the mitochondrial disturbance that underlies this disorder. Now, I don't know how much we didn't talk much about mitochondria, other than to say that's the little furnaces in every cell that takes fuel from our diet, combines it with oxygen to generate chemical energy. That process is deficient in Parkinson's disease. It's been proven in many different ways. If you were to look at muscle from patients with Parkinson's, just the muscle, not even the brain, you'll see that the bioenergetic capacity of the muscle is diminished in Parkinson's disease. So that's one component of the fatigue. Their muscles fatigue. The second component of fatigue is that same mitochondrial abnormality, the production of fuel within the neurons is deficient as well. And so whatever is involved in motivation and keeping that energy level up, and you know, dopamine is very much involved in keeping you energetic. If you give drugs that stimulate dopamine release, There's tremendous amount of energy. Think of amphetamine, cocaine. They all work by releasing dopamine, right? And if you lack dopamine, you're going to be immobile. You just have no energy. You have, in addition, no motivation. The dopamine released in the middle part of the brain, mesolimbic dopamine to the limbic brain, is what makes you feel good, gives you the sense of pleasure and well-being. And that's not normal either. So the sense of fatigue, yeah, so there's anhedonia, you know. And the thing is, I'll tell you a little story about this. Many of you may not know, but Abe Lieberman wrote a really beautiful article with videotape that Adolf Hitler had Parkinson's disease. You could see it in his handwriting, etc. He had a bit of an obsessive-compulsive personality that some patients with Parkinson's disease have. And he was treated with amphetamine because, the amphetamines were discovered in Germany as a way to open the airways. Amphetamines are nothing but synthetic adrenaline, like noradrenaline. It can cause a lot of problems. That was the way that they could increase his energy and make him psychotic. Yeah, so that's an interesting story. So fatigue is absolutely an intrinsic part of the disease. You can overcome it by taking coenzyme Q10, creatine, have a structured schedule where you're forced to exercise, even if it's 10 minutes a day on a treadmill, and just build it up. If you're forced to exercise, it becomes a habit, especially because people tend to be obsessive compulsive. Once they get into the habit, they will not spend the day without the exercise. And in a study that showed that forced exercise in a rhesus monkey with Parkinson's disease resulted in resprouting of dopamine neurons. And you know how that happened? Increasing blood flow to the brain. The animals were jogging on a treadmill for 3 hours every day for 6 months before they saw this dramatic improvement. And the growth factors that Dr. Hauser mentioned, GDNF, BDNF, were upregulated just by the increased perfusion of oxygenated blood of the brain. So I'm a big proponent of cardio aerobic exercise daily. But how do you get someone to do this, to run on a treadmill for 3 hours a day forever? Well, you don't do it that way if you're a human. You do 5 minutes on a treadmill, and you do it every day. And then after a week, you do 10 minutes every day for a couple of weeks. And after 3 weeks, you do 15 minutes a day. Shoot for 30 minutes a day on the treadmill or a stationary bike. Get a heart rate monitor. Get your heart rate up to 80% of your maximum heart rate. And I'll give you the formula. And if you do that for 6 months, you're going to have so much more energy, your Parkinsonism will be better, and your memory will be better, because that has been shown also to enhance the formation of new neurons in the hippocampus. So I'm obviously a big proponent of cardio aerobic exercise for Parkinson's disease.
And that's one of those examples of a return on your investment. That's a great example of one of those returns on your investment. And I think that's really important, because those are tools that are really important that are in your hands.
Which I guess leads into my question, amazingly enough, for Dr. Cimino, which is, I was not clear from your presentation whether you were saying that cognitive therapy also is good for apathy. Because if apathy is a major part of this disease, how do you make that leap to doing the exercise to begin with?
It's a chicken and egg problem.
Right, yeah.
How do you get them to initiate, to engage in the activity? Well, that's what we're looking at in this study, is we are looking at ways to engage individuals, to engage families. One of the things I mentioned is that if you think about initiation of movements in Parkinson's, that is facilitated by external cues. The metronome studies, the studies that have looked at placing visual cues as cues for initiation of movement. In this study, what we're looking at are some external cues to initiate behaviors. This is the first study that's looked at purely behavioral approaches to treating some of these symptoms. Yes. And there's a flyer in your bag.
Okay, we actually have time for 2 more questions. I know it's been a long day, and everybody's probably pretty tired, so we take 2 more questions, and then we're going to let you go.
Someone back there raised their hand. Oh, yeah.
Oh. Do you have any comments on the drug Azilect?
Do you want me to? Okay.
Yeah, that's yours.
So Azilect is, the way I look at it is it was a Me Too drug. The first one was selegiline. Azilect is rasagiline. I remember when I first started in this research in Parkinson's disease in 1984, the hot new agent was selegiline or Deprenyl. And that was led to a huge neuroprotective study in which patients who were recently diagnosed with Parkinson's disease, or we should say Parkinson's syndrome, that most likely had Parkinson's disease because none of the patients had been given levodopa yet, but they were very early on. And what was the endpoint of the study was to see if patients who were randomly given selegiline or Deprenyl would be able to go longer in their daily activities without needing levodopa. And it was a more complex study than that because it also had vitamin E alone, 2,000 units a day, had selegiline, 10 milligrams a day, or the combination of the two, or the combination of 2 placebos, so there are 4 groups. The study was halted after the second year, was changed because it was found by the data monitoring committee that individuals taking selegiline didn't need levodopa for much longer than the people that weren't on selegiline. In other words, the people that weren't taking that drug, Deprenyl or selegiline, seemed to have a neuroprotective effect because they didn't advance as fast. Later on, as the study, then everyone was put on selegiline. But later on, we found that selegiline actually improved some of the symptoms. And so we didn't know whether the benefit that we saw was due to a neuroprotective effect, actually slowing the death of neurons, or whether it was just alleviating symptoms by increasing the amounts of dopamine that were released, because what selegiline does, like rasagiline, I'm telling you this because then you'll understand more about rasagiline, selegiline inhibits the breakdown, the oxidation of dopamine. So by giving an individual selegiline, you end up having a higher concentration of dopamine and therefore relief of symptoms. And so it was a flawed study because in the beginning we assumed that selegiline had no symptomatic benefits. In other words, it wouldn't alleviate symptoms. And if we saw a delay in the need for levodopa, that would mean it's somehow inhibiting oxidation because it's an MAO, monoamine oxidase, generates a lot of free radicals. And the thinking in those days that it's the generation of free radicals in the metabolism of dopamine that causes the progression of the disease. That was the whole theory then. So we still use selegiline because it's very useful. I still use it because it'll delay the need for levodopa. Rasagiline was a variation of it that's a little bit more interesting because they decided to do the study late in a different way. And then they found that individuals, by delayed start with rasagiline, I was hoping that Bob Hauser could talk about it, but there was evidence that it slowed the progression of the disease. And so Azilect is now, though it's marketed as an agent as a supplement to levodopa, so that if you're wearing off and you add Azilect 1 a day, you can get more on time. That's how it's used, because it's an MAO inhibitor. It decreases the breakdown of dopamine and of levodopa. And that's how it's typically used. But there's a lot of evidence that in the very beginning of the illness, before you need levodopa, taking 1 Azilect a day will delay the need for levodopa because it may have neuroprotective effects. So it's a fascinating drug. The study showing neuroprotection was done differently than the selegiline study. Selegiline is still available. It's a lot cheaper than Azilect. Probably it's similar in effect. But I commonly use Azilect in young people who have mild symptoms, who don't really want to start levodopa, or I don't think really need levodopa. It's good to start them on Azilect. The caveat is that with Azilect, you have all these warnings. Be careful when you're taking antidepressants because you'll inhibit the breakdown of antidepressants. because they're metabolized by MAO, and then you might have too high a level of antidepressant, that kind of thing. But it's a very good drug as an adjunct to levodopa or as monotherapy at the earliest stages of the illness before levodopa is needed or before a dopamine agonist is added. Did that answer? So Azilect is very too much.
No. Perfect.
Okay.
And we have our last question of the day.
In his report this morning, Dr. Hauser presented the fact that some of us may feel funny when they get up, when they stand up. And he said that is good. He went without any explanation as to what does it mean that is good. Could you kindly tell me what is that's good, if you please? Thank you.
I really had a hard time understanding that. Someone who heard it clearer than I did, because I really have no idea what you asked.
Okay.
No, I heard something, but it didn't make sense to me.
Okay. Dr. Hauser was saying that some of us, when they get up, they feel funny.
That's a part. Some of us
lightheaded to something.
They feel funny. Get up feeling funny.
Do you know what he's saying? Who can
interpret feeling funny when he gets up.
Oh, feel funny when you get up. You get lightheaded. Okay.
And he said that is good. So what does it mean?
That's not good to feel funny when you get up. In fact, you should sit down when you talk. No, here's, what you're talking about, I think, if I understand, is that because the autonomic nervous system is involved in controlling blood pressure, and the illness, Parkinson's disease, affects that part of the autonomic nervous system, many patients feel lightheaded and queasy and sometimes just funny feeling in the head when they're up on their feet. And when they lie down, it's gone. That means that the blood flow to the brain is not good. It's dropped because the pressure drops and there's not enough blood flow. When there's not enough blood flow, you feel almost like fainting, and sometimes you can faint. And what makes that worse is the anti-Parkinson drugs. This is the irony. The levodopa and dopamine agonists improve motor function, but they worsen the orthostatic hypotension. That is that drop in blood pressure when you stand up. So in that case, you should wear TED hose up to the thigh, drink Gatorade to increase your blood volume. There are treatments for that. There's a lot of things we can do to alleviate that symptom.
Put your head between your legs.
Yeah, better to lie down.
Listen, thank you, everybody. I hope you enjoyed today. I congratulate those that hung in there till now.
Yeah, it's a
so
long day.
Come back next time.
Very good.
Thank you, everybody.